Hello, my name is Barbara Burton. I'm a professor of pediatrics at Northwestern University and director of the MPS Treatment Center at Lurie Children's Hospital in Chicago. Today, we will be reviewing some information presented related to Mucopolysaccharidosis type 2 at the WORLDSymposium 2022. The WORLDSymposium is a meeting devoted to research in lysosomal storage disorders. It's held annually and was held this year on February 7th through 11th in San Diego, California. Abstracts from the meeting are published in Molecular Genetics and Metabolism. So first, let me just remind you what is MPS II, also referred to as Hunter syndrome. This is a rare progressive lysosomal disease caused by deficient activity of the enzyme iduronate 2-sulfatase, or I2S for short. There's a variable clinical presentation with 2/3 of patients having cognitive involvement associated with developmental decline between about 18 to 36 months of age, followed by plateauing in development, and then ultimately progressive loss of skills. But all patients have significant somatic involvement, including coarse facial features, skeletal abnormalities, hepatosplenomegaly, airway disease, cardiac abnormalities related to gag deposition on the heart valves, retinal degeneration, hydrocephalus, and many other somatic manifestations. The standard of care is weekly intravenous infusion with idursulfase, but a number of other investigational therapies are out there, and data regarding some of these was presented at the meeting. So before we get into some of the presentations related to treatment, there were some presentations at this year's meeting designed to give us more information on the natural history of MPS II and also on the impact of timing of treatment on outcome of the disease. There was a retrospective natural history study of 28 children with MPS II evaluated on the Mullen scales of early learning, which looked at when development deviates from normal at what age in patients with MPS II, looking at both visual reception, expressive language, receptive language, and fine motor skills. And there were too many points of information presented to really go over each one, but one of the issues in developing treatment for the brain in MPS II has been lack of full understanding of the natural history of the developmental trajectory in the disorder. So this is helpful information using one particular developmental tool. There were also several studies that address that issue of the timing of enzyme replacement therapy with idursulfase and what difference this makes in terms of the ultimate outcome. And the first one I'd like to highlight was a description of a sibling pair where the younger sibling was treated prior to the development of symptoms at 1.7 years, following diagnosis in the older sibling at 5.7 years. And both siblings were followed for a period of over 10 years on therapy. And what was seen was that growth was very much better in the younger, early treated sibling who has remained within the normal range at average height from 6 to 12 years of age, whereas the older sibling started therapy at a height below the 3rd percentile and really has been on a negative trajectory ever since, such that his height Z-score is now greater than -2. It was also shown that both siblings did well with regard to their neuropsychological measures for the first 10 years, for the first 5 to 10 years of treatment. But after 10 years, adaptive skills declined in the late treated siblings, such that his scores were 84 as compared to 104 in the older siblings. So there was strong evidence from this sibling pair of a superior outcome with pre-symptomatic treatment. In addition to this, there were 3 sibling pairs reported from my own institution where we had treated the younger sibling pre-symptomatically, either after detection through newborn screening, where we then had an older affected sibling diagnosed as a result, or where the older sibling was diagnosed clinically and then a newborn baby was subsequently diagnosed. So the younger siblings in each of these 3 pairs were all treated at an age less than 3 months of age, whereas the older brothers started treatment between 21 and 36 months of age. And what we found was essentially that physical manifestations were completely prevented by the initiation of treatment near birth. Joint stiffness never developed in any of the younger siblings. They had normal cardiac assessments at follow-up, did not have valve involvement, and they did not ever develop the coarse facial features that are typical of the disorder. In addition, we found that they did not have any surgical procedures, whereas the older siblings had tonsillectomy, adenoidectomy, ear tubes. One had spinal cord decompression surgery. So our experience with these sibling pairs also supports very much the fact that manifestations of MPS II may be prevented with early therapy, but may be irreversible in some cases once they are established. And again, the importance of early treatment just underscores the need for newborn screening in this disorder. I'd like to move on now and talk about the results that were reported from several clinical trials in MPS II and begin with idursulfase intrathecal for treatment of neuronopathic MPS II. And of course, many of you who are listening to this may be aware that this has been around now for quite a few years. The trial of intrathecal idursulfase has been in an extension phase for some years because initially the trial did not meet its primary endpoint, but the FDA agreed to view the totality of the data and evaluate the results of the extension study. Intrathecal idursulfase, of course, is designed to treat the brain because idursulfase, which is our standard of care when given intravenously, does not cross the blood-brain barrier. We saw presented at the meeting some additional data from the phase 2-3 trial of idursulfase intrathecal, which involved 49 patients randomized initially either to receive the treatment or no treatment for 52 weeks. Following that, all patients received the intrathecal therapy. After 52 weeks, there was no significant between group difference in the primary endpoint, which was the change from baseline in the DOS2 GCA standard score at week 52. There was a trend toward benefit in the idursulfase IT group, but it was not statistically significant. However, pre-specified subgroup analysis did identify a potential cognitive benefit at week 52 among children less than 6 years of age. When those patients less than 6 years of age were categorized post hoc as having either missense or other types of IDS variants, a very clear benefit was shown in the patients under 6 years of age with missense variants with a p-value of 0.0174. And again, this is looking at the difference in the least squares mean change from baseline in the DOS2 general conceptual ability GCA score at week 52 between treated and untreated children with missense IDS variants. So this suggests that there may be a role for intrathecal idursulfase in the treatment of neuronopathic MPS II, particularly in a subset of patients. There was, in addition to the clinical trial data on intrathecal idursulfase, there was also a report of a semi-structured interview conducted after phase 2-3 trial enrollment with non-clinical investigators who were involved in the trial, paired with 56 patients who were treated with idursulfase IT in the extension study. And the goal of these interviews was to evaluate treatment effects that were not fully captured by trial outcome measures. And the results of these interviews were that 49 of 56 patients were rated by investigators as having disease that was either improved or improving, stabilized, or showing a slowing of progression when receiving idursulfase IT. Now, moving on from idursulfase IT, there were several studies reported of novel brain penetrant enzymes that are being investigated, again, for the treatment of the brain in patients with MPS II. The first of these was a phase 1-2 study of DNL310 is an investigational IDS fusion protein engineered for efficient CNS delivery and also for distribution to the peripheral tissues. What was reported was data on 2 cohorts from the phase 1-2 study. Cohort A, which enrolled 5 subjects with a dose escalation protocol, and cohort B, which enrolled an additional 12 subjects exploring several different dose levels. All patients received standard of care idursulfase prior to enrollment and then were switched to the investigational product without a washout period. And the data presented showed that there was a general decline in urine GAGs and in urine heparan and dermatan sulfate, even in these patients who had already been on long-term idursulfase treatment. In addition, it was shown that all patients achieved normalization of their cerebrospinal fluid heparan sulfate levels. All patients also achieved normalization of several CSF lysosomal lipids that were measured that secondarily accumulate in addition to the glycosaminoglycan heparan sulfate in patients with MPS II. There was one severe adverse event reported, that was anaphylaxis. All others were mild to moderate, and most of the adverse events that were felt to be related to the investigational product were infusion-related reactions. Based on this phase 1-2 study, a phase 2-3 study is planned and is expected to be initiated in the coming year. In addition to the study I just described, there were also data presented on another brain penetrant enzyme replacement therapy for MPS II called pabinafusp alpha, also referred to as JR141, is the IDS enzyme fused with an anti-human transferrin receptor antibody, again designed to cross the blood-brain barrier, but also to treat the somatic manifestations of the disease. 2 studies related to this product were presented at World. One was a phase 2-3 fixed dose study conducted in Japan, and there were also data presented from a phase 2 dose finding study conducted in Brazil. Both of these studies used a dose of 2 milligrams per kilo of JR-141. The results of these studies showed that heparan sulfate concentrations in the cerebrospinal fluid were markedly decreased in treated patients and then remained low throughout a 104-week study. And this also included patients who were initially started on a higher dose of 4 milligrams and subsequently reduced back to the 2 milligram per kilo dose. Neurocognitive studies showed long-term stabilization or improvement in most patients. Liver and spleen volumes decreased significantly in the patients naive to enzyme replacement therapy and were maintained in most patients switched from idursulfase to JR-141. And it was concluded that the efficacy of JR-141 against other somatic symptoms was comparable to that of idursulfase. Drug-related adverse events were mild to moderate and generally manageable. There is a phase 3 study of JR-141 about to be initiated. In fact, it has been initiated in the United States. Finally, with regard to interventional trials, there were interim data reported on an MPS II gene therapy. This is the RGX-121. This is a recombinant adeno-associated virus, AAV serotype 9, capsid containing the human iduronate 2 sulfatase expression cassette. This is a phase 1/2 study, open label dose escalation trial being conducted in patients with the neuronopathic form of MPS II, ages 4 months to 5 years. Assessments include CSF plasma and urine biomarkers, cognition, language, and motor development, as well as neuroimaging. 9 patients have been enrolled to date in 3 dose cohorts, and the data presented suggests that RGX-121 has the potential to provide sustained CNS clinical outcomes and additional systemic effects. The product was reported to be well tolerated with no drug-related serious adverse events. Heparan sulfate concentrations in the CSF were consistently reduced in treated patients, and interim neurodevelopmental testing demonstrated ongoing skill acquisition in multiple domains, although it is really too early to judge whether the therapy is changing the neurodevelopmental trajectory for these patients, since this is a disorder that develops over years during this preschool period. They did show that plasma I2S enzyme expression, total urinary gags, and abdominal ultrasound imaging suggested evidence of systemic efficacy as well, even though the gene therapy is administered into the cisterna magna. So there is some evidence that it may cross out and provide somatic benefits in addition to the central nervous system benefits. The therapy, the trial, of course, is ongoing. They have also added a cohort of patients over 5 years of age. So we expect to see more data with each passing year coming from this initially promising gene therapy trial. And then finally, there were data presented from our registry for patients with MPS II called the Hunter Outcomes Survey, which has been collecting real-world data on the natural history of MPS II and the impact of enzyme replacement therapy since 2005. Data were reported on patients from HOS and the history of HOS with regard to generating publications and abstracts was reported. Among the the publications that have emanated from Haas, we've seen data on long-term clinical outcomes with idursulfase, on the tolerability of treatment, which appears to be very high. We've seen evidence of improvement in or stabilization of somatic manifestations, which is sustained over many years. And there has also been shown to be an association between idursulfase treatment and prolonged survival in all patients with MPS II, both neuronopathic and non-neuronopathic. Of course, with any real-world registry study, there are drawbacks, and one is that data completeness is not ideal, certainly, including even when the core variables are assessed, and this has to be taken into consideration. But much has been learned from this registry over the years. It's been very productive, not only in showing the efficacy of treatment, but also in demonstrating differences in care patterns across different geographic regions of the world and suggesting areas in which care may be improved. So with that, I'll conclude. There was a lot to learn about MPS II this year at World, and hopefully this synopsis has been helpful to you.